I'm Nick Ferran. I'm a consultant trauma and orthopedic surgeon specializing in shoulder and elbow surgery. I'm passionate about delivering awake shoulder and elbow surgery under regional anesthesia where appropriate, and have interests in treating conditions such as frozen shoulder, rotator cuff tears, fractures and dislocations around the clavicle, shoulder, and elbow, and nerve problems such as cubital tunnel syndrome and carpal tunnel syndrome. If you have any of these problems or want a consultation about your shoulder or elbow, please get in touch with our practice management team. So the most common cause of shoulder dislocation is trauma, often due to sporting injuries or high energy falls, which cause the shoulder to dislocate out the front. Sometimes, in more rare cases, the shoulder can dislocate out of the back due to seizures, or in very rare cases, electrocution. For some patients, they have generalized laxity problems, or sometimes problems with how their muscles function, and they can cause the shoulder to dislocate in multiple directions, and this is called multidirectional instability. After a traumatic shoulder dislocation, there's often intense pain and muscle spasm as the ball comes out of the socket in the shoulder. This often causes swelling and usually an obvious deformity, and can cause a limitation to movement, particularly rotations, depending on whether the shoulder has gone out the front or gone out at the back. Some patients who have instability rather than dislocations can have the sensation of the shoulder sliding out of joint without it fully dislocating, and this would not cause the swelling and deformity of a true dislocation, but can still be unnerving for the patient and can often cause them to drop things as they get the sensation of the shoulder coming out. The initial treatment of a shoulder dislocation is an emergency procedure to try to get the shoulder back into joint. This can either be done in an emergency room under sedation, or sometimes requires general anesthetic to allow enough muscle relaxation to put the ball back in the socket. Then the focus of treatment is to work out how much damage has been done and whether surgery may be required to prevent future dislocations. Patients may need to be in a sling temporarily just for a few days, but we try to get them back to early movement as soon as possible with the care of a physiotherapist. And then we do special investigations to look at the shoulder joint, socket, and soft tissues around it to try to work out whether surgery is required to prevent future dislocations. Most surgery for shoulder dislocation is done through keyhole surgery, but in rare cases, in severe dislocations, we may need to do open surgery with moving bone to build up the shoulder socket to prevent future dislocations. But by far and by large, shoulder dislocation surgery is keyhole surgery. It's often day case, and we try to get patients back to activity as soon as possible. After a shoulder dislocation, patients often have a reduction in the emergency room. They're often put into a sling, but I recommend that that sling be removed within a week and the patient gets back to activity as soon as possible, usually with the care of a physiotherapist. If recurrence is a problem, then you may need an operation, often through keyhole surgery, to stabilize the shoulder. After shoulder stabilization surgery, patients can expect to be in a sling for up to 3 weeks, will need physiotherapy for up to 6 months, and often have to avoid contact sports for the first 6 months in order to prevent a redislocation. It can sometimes take up to a year for the shoulder to get back to normal, but during that time the patient is getting back to activity. For sports patients who have the backup of team physiotherapy and rehabilitation, we can accelerate this program but often we try to avoid return to contact sport until 6 months, even in elite players. So after a dislocated shoulder, patients should be able to get back to normal activities of daily living within a few days as the pain settles. Certainly I would encourage weaning the sling provided within a week. I'd expect patients to get back to dressing themselves as soon as possible. Driving would probably occur when the patient feels they're able and competent to control a steering wheel without pain. Certainly I wouldn't recommend driving in a sling. In terms of sporting activity, this is often guided by the physiotherapist after a dislocation, and certainly contact sports would be avoided for the first 6 months. If the patient has surgery, then they may be in a sling for a longer period and may be able to do some activities of daily living, such as dressing themselves, etc., but this may be limited by the sling. Driving would be more likely to occur after about 6 weeks, with return to contact sports by about 6 months. Again, guided by your physiotherapist and surgeon after surgery.